Greetings. My name is Vanessa Johnson. I'm with the Ribbon a Center of Excellence located in Largo, Maryland, USA. The name of the presentation is Menopause and Women Living with HIV, Voices, Visibility, and Vitality. You'll hear community insights on menopause, support, and gaps among women living with HIV. This presentation highlights the collective voices and lived experiences of women living with HIV as they navigate menopause, aging, and health equity. It emphasizes the perspectives of Black women and long-term survivors whose stories have been missing from research and healthcare conversations. Through a shared narrative, we explore what it means to age with dignity, to be heard by providers, and to gain a grace and space in systems that often overlook our experiences. This presentation presents both testimony and strategy, advocating for compassionate care, informed providers, and policies that recognize menopause as an integral part of the HIV care continuum. For too long, discussions about women and HIV have centered on youth, fertility, and prevention, making midlife and older women invisible. Yet women living with HIV across communities are aging, they're raising families, and we are leading organizations and redefining what it means to survive and thrive. As we approach menopause, we carry the weight of years of treatment, stigma, resilience, and wisdom. Our stories challenge the idea that aging with HIV is only a clinical outcome. It is a journey of mind, body, and spirit. Among women living with HIV, menopause often occurs early and unexpectedly. Many of us aren't informed about what to expect or how to tell the difference between changes caused by medications, stress, or trauma. Some of us celebrate the end of our periods, as I did, only to find out later that menopause brought its own challenges like hot flashes, night sweats, fatigue, mood swings, and persistent pain. One woman shared, "I thought I was losing my mind, but it turned out to be menopause, not my meds." Another woman said, "Doctors asked if I was having sex, but never explained what menopause might mean for me." These are not isolated stories. They reflect a pattern of dismissal where women's concerns are minimized or misinterpreted within systems that too rarely listen to us. Menopause for women living with HIV is more than just a biological change. It's a mix of multiple health challenges. We face increased risk of heart disease, weaker bones, and mental decline, all while managing the long-term effects of antiretroviral therapy. Many of us lived with HIV for years, and our bodies bear the success of our survival and the impact of this treatment. Studies such as that have been done in the United Kingdom, such as PRIME, and the United States, which combines the multi-center AIDS cohort study and the Women's Interagency HIV study, explore the effects of HIV and aging among diverse populations. These studies have confirmed that women living with HIV often experience menopause earlier, with more severe symptoms and less guidance from our healthcare providers. But numbers alone cannot tell the full story. Behind each statistic, or behind the data, should I say, is a woman who has had to advocate for herself in exam rooms, asked for screenings that should have been routine, and endured silence from clinicians unprepared to discuss menopause in the context of HIV. The experiences of Black women with HIV highlight the depth of medical mistrust. It's not paranoia, it's memory. It stems from years of being asked invasive questions about sex, judged for reproductive trust choices, or treated as cases rather than individuals. Many of us have never had our hormone levels checked or have been told about menopause treatment options. Even in clinics that focus on HIV care, menopause is often ignored. As one long term survivor said, after 30 years of treatment, I had to explain to my own doctor why I'm asking about menopause. Why am I the one that's teaching them? This shift, where the patients are educating the providers, reveals some systemic failures that cannot be fixed by resilience alone. The journey through menopause is closely connected to the trauma many women living with HIV have faced. Trauma, whether from violence, racism, poverty, or healthcare mistreatment, influences how we view, and how we see our bodies and interact with care. For some, coping involves self medication with food, substances, or withdrawing. For others, it has involved turning pain into purpose through advocacy and peer support. We understand that trauma doesn't end when the viral load is reduced, it remains in the body, impacting our heart health, our sleep, and our emotional well being. Recognizing this reality involves creating trauma informed systems that view healing as a fundamental part of medical care and not a separate service or optional conversation. In the absence of comprehensive medical guidance, many of us turn to each other. Peer support has long been a cornerstone of HIV care, and it must extend into conversations about menopause. Through peer navigation programs, support groups, and online forums, women are sharing strategies for managing symptoms, advocating for themselves, and reclaiming the joy in their bodies. Community knowledge fills gaps left by the healthcare systems. We teach each other how to prepare for hormonal changes, how to ask the right questions, how to seek the right test, and how to find providers who respect us. In this collective learning, we are redefining expertise, honoring lived experience as data, as evidence, and a legitimate source of wisdom. Access to menopause care should not depend on race, insurance status, or geography. Yet these factors still influence who receives informed and compassionate care. Achieving equity requires more than cultural competence. It demands a systematic accountability that is missing. This involves investing in provider education, funding research that includes diverse participants, and making sure treatment options are accessible and affordable for all women living with HIV. Community advocacy remains essential. Groups like Ribbon, the organization I work for, a Center of Excellence, and the 4M Network, among others, are working to emphasize the significance of menopause in HIV policy and program development. We are promoting inclusive research, improved data by gender and race, and partnerships that place women at the forefront, not the margins of decision making. It's time for the healthcare systems to recognize menopause as a vital part of HIV care. This involves proactive screening, open communications, and collaborative partnerships across all disciplines. It also requires training every provider to understand how menopause and HIV interact and to listen without judgment or dismissal. Clinics should use waiting rooms, digital portals, and health education materials to share age specific information about menopause. Providers should initiate conversations rather than wait for women to bring them up. And every woman, regardless of age or viral load, deserves to feel that they are being seen, respected, and supported as she ages. The story shared here remind us that menopause and HIV are not separate stories. They intersect in the lives of real women whose courage has sustained the HIV response for decades. We are not invisible. We are not done learning nor leading. As one advocate said, menopause should be a part of HIV care and not an afterthought. Our collective vision is clear, a future where aging with HIV includes understanding, dignity, and joy. These references reflect the studies and community reports informing this presentation, and we end this presentation by saying this. We close by honoring the women whose voices made this work possible and the community partners advancing health equity every day around the world. Thank you very much for your time and attention.